quick. Okay, we've started. So to begin, I'm just going to go with a real quick roll call on today. Before we go through the roll call, I just want to tell you that this is the observational training for the AlcHepNet. But before I pass this off to Savannah, who will lead us through the training, I'm just going to go through the roll call. So I'm going to start with UT Southwestern. Is Samantha on the call? No, Samantha is not on the call yet. Okay. Moving on to University of Pittsburgh. Is Carol on the call?
Yes, I'm here.
Hello, how are you?
I'm good. How are you?
Good. From University of Louisville, is Amar on the call?
Yes, I'm.
Great. Jeanette?
He's not there.
Sorry, I can't hear you very well.
Pranit is not here.
Oh, he's not? Okay, great. Thank you for telling me. And is Chanakya? Sorry.
Yeah, that's me. I'm here.
Okay, great. Thank you.
Mm-hmm.
Moving on to University of Massachusetts. Is Mary on the call? No? Okay. Monique?
Yes, I'm here.
All right, thank you. And Donna?
No, Donna is on an extended vacation. I think she already rescheduled this.
Okay, that's right. Thank you for reminding me. And then from VCU, Rebecca and Stephanie? We're here. Okay, great. And from Mayo, Amy, Janelle, and Kevin?
Yes, Kevin's here. Amy will be calling, or she'll be coming on here in just a few.
Okay.
She's working on some patient stuff right now, and then Janelle's also on the line.
Okay, great. Thank you. And from Indiana University, Jen, are you on the call?
I am.
Great, thank you so much. And then Savannah is on. From Cleveland, Annette?
Hi, I'm here.
Hi. And then Vathi?
Yes, I'm here too.
All right, thank you so much. All right, well, I think that's everyone. So I'm just gonna go through some updates. This morning, I sent you an email with a bunch of documents. And I just wanna let you know, all those documents are on Box as well. And if you could give me the documents for your sub-Is as soon as possible, I think I put the deadline as February 1st, that'd be great. But I wanted to check in to see if you had any questions about anything on the email. Okay, well, if you do, let me know. But everything's in Box as well. So updates on the observational protocol. I just want to let you know, hopefully we'll submit the final protocol this Friday. The new common rule is going to go into effect the 19th, this Saturday. So hopefully we'll submit this and won't have to put the new regulations in, but in the next amendment or the continuing review, we'll have to make changes for the new common rule. Hopefully we hope to get approval by the end of this month or early February. And then from there, you'll change the documents and put compensation, blood specimens, and then add site personnel. I want to let you know also that there's going to be an exemption process for subjects that don't meet all of the criteria for inclusion or exclusion. So I'm working with Dr. Chalasani and Dr. Galway on this. Once we have a finalized policy and form, I will send that out to all of you. And it will be more internal, it won't be through REDCap or anything. It'll be just a document that you'll fill out, you'll send to me, and then I'll get approval with the PIs so you can use a patient that doesn't meet the inclusion or exclusion. And then I'm going to move on to the clinical protocol updates. Hopefully we'll have a final version of the protocol this week. After I'll send it to all the investigators, the PIs of all the sites. Once I have their approval, I will send it to all of you for your review, because I really want to make sure that everything makes sense, the language, or if I've missed something. Some of you have sent comments back on the observational protocol of mistakes, so thank you. If you see anything, please let me know, because before we submit it to Word, that'd be great to submit the changes. And then for the IND, I'm still working on the IND. Hopefully by the end of this month or early next month, we'll send the IND. Also, other updates, sorry, there's a lot. There was a face-to-face meeting in Dallas that I attended. I will send everyone the notes to that. Hopefully by next week. I haven't had time to type them up, but I want to keep you guys in the loop. And then if you have any questions about the meeting, just let me know. Also, UMass is diligently working on the website. It's very professional and aesthetically pleasing, so get excited about that. It's really nice. Then I would also like to introduce you to a returning data manager at AUDIT-C. His name's Ronnie Ovando. He's mainly overseeing the data and data queries, so he won't be REDCap. Jacob's more REDCap oriented, but all the data and data queries for both the observational and clinical trial. So over time, you'll receive emails from him. And I've also added his contact information to the staff directory and box. So if you want to email him, it's right in there, his email address, or you can contact me. Just a reminder that the protocol that we will be going over today, some parts could change by tomorrow. So if changes are made, I will let you know. So from now on, I'm going to pass this training on to our project coordinator of the AlcHepNet consortium, and she's also the IU coordinator of this trial, the observational trial, Savannah Musselman. So thank you so much.
Hi, everyone. Like Kayla said, my name is Savannah, and I'm the coordinator for the observational trial and the program coordinator for IUCCC. The observational protocol has been something I've been working on for quite some time. So if you have any questions or even suggestions or anything, please let me know. And again, like Kayla said, the protocol is not completely approved by WERB, so some things that I may go over today may change, and we will let you know as soon as that happens. So, getting started. This is a few of the things that we're going to go over today. I thought they were the most important when trying to learn the protocol. I hope that you've had a chance to look over the protocol or some source docs or the questionnaires a little bit, and may make this training go a little bit smoother. If not, I'm going to go over everything, and at any time, feel free to speak up and ask a question. Kind of keep this informal as possible. So here again is the list of the coordinators and email addresses for everyone, just kind of keep you familiar with who is from where, and email addresses if you have questions. So getting started. The protocol, this is the planned enrollment for the 5 years. We plan on enrolling 1,260 subjects. There are 3 arms. The first arm is patients with alcoholic hepatitis. The second are heavy drinkers without alcoholic hepatitis, and then healthy non-drinking controls. In the first year, we plan for the accrual roles to be 23 per site, so 12 alcoholic hepatitis cases, 7 heavy drinking controls, and 4 healthy controls per site. There will be 4 visits. Baseline visit is where all 3 of the arms will visit. This will be the only arm that the healthy controls. This is just a one-time visit for healthy controls. The alcoholic hepatitis patients will be seen at the baseline, week 4, week 12, and week 24. And then the healthy controls will also be seen at week 24, which is day 180. We kind of were going back and forth whether to call them day 30, 90, or 180, but we decided to go with weeks. So I'm just trying to get you familiar with these terms. Also, the alcoholic hepatitis patients after week 24, if they are still on study, they will be followed up through medical records every 24 weeks until the end of study. Does anyone have any questions about any of this so far?
Yeah, hey Savannah, this is Revati from Cleveland Clinic. The alcoholic hepatitis patients, are we not going to see them on day 360 also?
There is no day 360 visit.
Oh, so it's just both the heavy drinking controls as well as alcoholic hepatitis. The last one is day 180?
Yes, that's the last visit we will see them.
Okay, great, thank you.
So heavy drinking controls will be the study at day 180.
Savannah, this is Sam from UT Southwestern.
Hmm?
So when we follow up every 24 weeks, is that just a phone call, or do we like schedule an appointment?
So I will get to the source doc later. It's just 3 data points. Are they still alive, still drinking, and their MELD score if available?
Okay,
so
thank you.
Every 6 months, yep, until the end of study, which will be 5 years. If you can keep up with their medical records, sometimes you won't see anything else, so that's also something. This is a detailed list of the scheduled events that will be happening. It can help kind of put into perspective of what will be happening at each visit. If you need this for reference to look at, this is a good slide as well to see what you'll be collecting and what questionnaires, what things you'll be doing during the visits, also who is going to the visits. If you see here where my mouse is, that this is for IU. We're doing hepatic function and the BMP. We decided on this for IU because the CMP does not collect direct bilirubin. So we, Dr. Gari decided that was an important thing that we need for the study. If your site, it does collect, feel free to use the CMP instead. So this is kind of something that you'll have to discuss and figure out with your lab. Also, not sure if all sites are doing PBMC yet, and also stool is the only optional thing that we have. So moving on. Does anyone have any questions on this? Okay. This is another kind of rundown of what each visit will include. History, physical exam, anthropometric measurements, lab exam, questionnaires, biospecimens. So we just changed this yesterday. So the inclusion, exclusion, and the definition of alcoholic hepatitis, we're saying that it is an average daily consumption of greater than 40 grams or 280 grams a week. 40 a day or 280 a week for women, or an average of 60 a day or 420 a week for men for a minimum of 6 months and within 6 weeks prior to the study. And then total bilirubin above 3, and if the diagnosis age remains in question, a liver biopsy will be required. So this is the inclusion criteria for alcoholic hepatitis patients. Like I said, we just changed some of this yesterday, so bear with me. What's that? Okay. So they have to have alcoholic hepatitis, bilirubin above 3, subject or guardian ability to understand and willingness to provide written consent, 21 years or older, and then re-enrollment of an alcoholic hepatitis patient is permissible up to 4 times if the donor presents the new episode of alcoholic hepatitis 24 weeks or longer after the most recent enrollment in the study. So you can re-enroll alcoholic hepatitis patients. And this is the exclusion. I'll let you read over that. Okay. And then this is the inclusion for heavy drinkers. They have to have on average the same as the definition of alcoholic hepatitis is greater than 40 on average a day, or 280 a week for women, and 60 a day for men, or 420 a week for men. And we're considering 14 grams of alcohol, 1 standard drink. And then this is the exclusion, which is subject to change. We'll let you know if this changes. So it's the past evidence of alcohol liver disease defined by bilirubin greater than 2, AST greater than 1.5 of upper limit of normal, any hospital admission, presence of esophageal varices or ascites, and then liver disease significantly caused by hemochromatosis, autoimmune, Wilson's disease, NAFLD, and acute viral hepatitis. And then the same, it has to be less than the average. Exclusion can't be less. And then total bilirubin greater than 1, INR greater than 1.4, or ALT greater than 40, they will be excluded. Any questions on the alcoholic hepatitis or heavy drinker so far? Okay. So for healthy controls, they have to have an audit score of less than 4 for men, less than 3 for women. We'll show you the AUDIT-C in just a second. They have to have a consumption of less than 1 standard drink a week during the 6 months prior to enrollment. And then, of course, the ability to understand and willingness to provide written consent. And the healthy controls have several exclusions, of course, because they have to be healthy. So I'll let you guys read over this real quick. Pretty common ones: no HIV, BMI has to be less than 35. I think I put greater than. No, that's exclusion, that's right. Does anyone have any questions on these exclusions or inclusions for healthy control? Okay. So during the biorepository training, Amy and Peter went over this a little, so I just wanted to show you it again to keep you familiar with the six digits that you will be using for your site. UMass will be providing all of the aliquot labels for the aliquot that your lab will use, but each coordinator will need to create their own individual labels for the tubes that if they are sending it to the lab. And I created a sample of what could be on the label at the bottom. You'll need to work that out with your lab. So one thing to keep in mind. When you're enrolling, it's important to keep a master subject log. I'm sure most of you know this just for regulatory reasons. An enrollment log is also helpful to keep so that you can look up information you need, like addresses, birth date, phone number, email addresses, things like that, so that if you need to get a hold of the patient, you have somewhere that all of that information is separate from. While we will try to keep screen fails to a minimum, there of course will be some. Teeth is to make sure your patients that you can call ahead of time, like healthy controls and heavy drinkers, you screen them using the inclusion-exclusion. Screen fails will happen though. Just remember to do the steps necessary after. And also remember that screen fails will still be assigned an ID number. So after that screen fail, just continue using the next number like you would if it was a normal patient. We are also going to keep the samples of screen fails and we'll ship them quarterly to biorepository like they're normal samples. Just letting it known in red cap that they are screen fails.
Savannah, I have a question about the screen fails.
Mm-hmm.
Are these people who sign a consent form and then like they no longer qualify, or like say we go on to the EMR, that could be potential subjects, and then, I don't know, the next day the Billy's too low or something, and so it'd be, you know what, do you get what I'm saying?
Yeah.
I guess,
So
like, what's, like, the strict definition of a screen fail?
So things that can happen if you are screening a healthy control, you draw their, you ask them all the inclusion, exclusion, you bring them in for a visit. We don't have a screening visit, so that will be their baseline visit. So if you draw their blood and they end up having, you know, HIV or something and not telling you, then there'll be a screen fail. So we don't have a screen visit set up. Yeah.
Okay.
Does that make sense?
Yes.
Okay. Does anyone else have any questions? Okay, moving on. So all the source docs are kept in the box folder. There's a link that you can go to them. I'm going to show you most all of this source docs right now so we can familiarize with them. So this is the box link that it would take you to with all of the source docs in them. They're in alphabetical order. Jacob's been awesome and he's made us packets. So I will go through the packets with you to show you. So I'll start with the screening packet. So this would be what you would do over the phone or through EMR and screen. So we have the eligibility forms. So this would just be the inclusion, exclusion. Make sure you check yeses for inclusion, no's for exclusion if they apply. Make sure you have them enrolled, assign them a number, and then have your PI sign off on it. You'll do that for each. Yep.
Sorry, this is Revati again from Cleveland Clinic, and you might have answered this question, but I just wanted to make sure that I got it right. So with the exclusion criteria and the screen fails, so I know we spoke about, for example, if we were to bring a patient in for a screening visit and then we found out later that they were HIV positive, or we did another panel and they were to be a screen fail, then, you know, obviously we'd exclude them.
Yes.
The question then remains, if we wanted to draw labs to make sure that they fit the inclusion criteria during the screening visit, for example, an HIV panel, which is not a regular test, who would then pay for that?
So you're saying if you brought them in and pulled their labs and then you brought them in again?
No, so for example, if we did sort of a chart review and, you know, they matched all the criteria, we brought them in for a screening visit because there are certain labs that are not available, like for example, an HIV panel.
Mm-hmm.
And we asked them to get an HIV panel so that they match the criteria.
That would be on the study. Those are the labs that we need. So
Yeah.
So it would be on the study?
Yes.
Yes.
Oh, the study will be for any labs that we do during the screening visit, just to be clear about that.
Yes. Well, yes, because the screening would technically be the baseline.
Mm-hmm.
So they would just be as a screen fail, and then yes, the study would pay for that visit, and then they would be out of into study, screen fail.
Okay, perfect. Thank you so much for clarifying that.
Sure. Okay, moving forward, this will be the same, just healthy controls, inclusion, exclusion, fill this out, make sure you assign them a number, investigator sign, healthy controls, same thing, inclusion, exclusion. Sorry if I'm going fast. We've just went over the inclusion, exclusion, so if you have any questions, just let me know. And then also is the screen failure, if that happens.
Savannah, this is Kayla. Just to make sure, some of these CRFs have not been updated. Just like were they updated? Do you know that?
Yeah, we updated.
Oh,
we did
did
yesterday.
Okay, I thought they were. Thank you.
If they should be, if you see something that's not updated, let us know if you notice something, anyone, because we were rushing yesterday trying to get everything updated for today. So this is the screen failure. Just leave this, fill this out. You'll notice at the top of each page there is little information to fill out. Make sure you do this for each page so that if you were to drop a bunch of papers, you would know which papers belong to who. And then also the AUDIT-C is for healthy drinkers, healthy non-drinkers only. This is to ensure that they are not drinking, and if they pass this, it's another way to tell that they are not drinking and telling the truth. So that can be used as a screening tool when you're on the phone trying to screen people. Okay. We'll move on to the baseline packet, if that's okay with everyone. So this is just like a cover sheet, enrollment information you can keep in your binders to keep track of people. It also will be useful when the RCT study comes around. Subject profile, all these questions you can ask them at the visit after they are enrolled. And so you can use this as a source document. You don't have to fill it out twice. Just normal demographic questions, medical surgery questions. Medical and surgical continued. And then we also have family history of alcohol use. We changed this up a little bit. If you notice, people from VCU and Mayo, this question's worded a little different than it used to be in TREAT. We're now doing natural, biological, blood, family, and then also foster, if it applies. And then, of course, ConMeds. This is where you fill all the ConMeds out for your patient. And this awesome little sheet is something Jacob created. This will be a cover sheet. It helps you know everything that is at baseline. These are all the things that you need to do. These are all the forms you need to fill out and make sure that you ask all these questionnaires. So it's helpful if you entered it into the red cap, completed, not completed. It's a helpful little one-stop shop.
Basically for those people who put the patients into the system. So
I was saying, this is like mini.
Moving on, this is the medical information that we will be collecting for the study. Liver biopsy. These are the specific medications that the PIs have decided they want to hone in on. So these are the only ConMeds we will be collecting. So if they are taking anything else, we won't be writing that or putting that in their ConMed forms. These are the only ones that we are want to know about. So this is important to know, and a little less work. We're also doing anthropometric measurements on the patients. So you'll do around the largest point around their belly button, hip, wrist, forearm, and upper arm. So we can see the changes in their weight and size. Of course, we're doing liver disease scoring and Child-Pugh. We'll be doing vital signs. Standard of care. These are all things that within 30 days, if they were done, we would like to collect that and know that information. If they were not done, we aren't ordering them. We're just, if they were done, we would like to know. If not, no big deal. And then fiber scan, if it was done. And this, of course, the physical exam. If you have a PI come and see your patient while it's in clinic, you could just have them fill out this sheet right here for you, so you don't have to, or if it's on medical records, you could fill it out yourself. And this physical exam, of course, is specific to liver disease.
I have a question about the physical.
Uh-huh.
Does the physical exam need to be completed by an investigator that's on the study, or can it be done by any physician not on the study?
I'm pretty sure, I don't know if anyone else knows the answer for sure, that it does need to be somebody either a sub-I or the PI.
Okay,
Does anyone know for sure? I think
that's what I thought, but I just wanted to make sure.
This is Kayla. That's correct.
Okay, yeah, I thought so. I just didn't want to speak out of.
Okay, thank you.
Yeah, no problem. Anyone else have any questions?
Hi, this is Monique. I think I just missed something. Does the physical exam have to be done by a PI or a sub-I?
Yes.
Oof. Okay,
Yeah.
that's problematic potentially. Typically, these folks are hospitalized.
Yes.
So that means we have to drag up one of the investigators to do an exam, even if it was they get daily examinations during the course of their hospitalization, and that's entered into the EMR.
I would think still yes. Maybe you could print off the medical record. Yeah.
I misspoke. No, it does not. I'm sorry.
Okay.
Oh, thank you.
Sorry.
Okay.
No.
Thanks.
The problem, Dr. Sabu asked.
What's that? Okay. Moving on, these are the labs that we'll want to collect. They're pretty normal for liver. Lipids and other labs. After the first visit, of course, HIV will be necessary for healthy controls, but after that, lipids and these other ones are not, will not be protocol deviations if you do not collect them. If they were collected, we would like to record them, but if not, that's okay. And then this will be the tracking of the blood in urine. So you could, I'm not sure how everyone does it, but we send this paper off with the blood, we fill it out, and then the lab will fill out the rest. And then they will give it back to us, and we will enter it into REDCap. And then the same goes for stool and PBMC for the sites that will be doing PBMC. If your patient was hospitalized during enrollment, this is a discharge form that we like with a few extra questions. Move to the second page. And that is the baseline packet. Does anyone have any questions? Okay. I will move on to the follow-up packet, which will be very, very similar to the baseline packet. So this is another cover sheet. Let me help you. So it has the same questions pretty much, maybe a few less. Specific medication again. Some anthropometric measurements. Liver disease scoring. Vitals again. And then standard of care if they were done in 30 days of that visit. Physical exam again. And labs again. Sorry if it's so repetitive. I just wanted you guys to see these packets to know what's in it. And then stool, and then PBMC, and then that's it. So next I'll show you the questionnaires. Wait. Okay. Another awesome little cover page. So the audit, this will be used for all patients each visit. I'm sure most of you, if you've done liver, you've seen the audit before. We're also going to do the chronic liver disease questionnaire, have the patient fill this out, and you fill this up here out, you the coordinator. And they'll put an X in whichever box matches. I'll let you guys read through the questions later. I won't want to take up too much time going over that. And then the next is the timeline follow back. I'm not sure if anyone's used this. This is another way of keeping track of the alcohol consumption. So say that the patient, you're seeing them on Valentine's Day. What I've learned from another coordinator, Jennifer, taught me, it's helpful to highlight the last 30 days for them and then have them fill out 30 days of what they've drank. Of course, they are not going to be able to remember every single day perfectly, but most of them are creatures of habit and drink around the same thing every day. So it's just their best average. So that is the questionnaire. Does anyone have any questions about the questions? Okay. So every form is in here individually and in packets. So if you're looking for something individual, you can print that off too. This is the medical record follow-up script and phone script that I was talking about. So say you have an alcoholic hepatitis patient that misses their day 30, you will call them, and this is the script they can use. You could just answer these 3 questions, so it will still be a missed visit because they missed the window. But if they answer, they could answer these 3 questions. And if they don't answer and aren't answering, just look through their medical records. And this will also be the 3 questions. You will look in the medical records for alcoholic hepatitis patients every 24 weeks after week 24. Does that make sense to everyone, or was that? Okay. Take the silence as a yes. Okay, so this is the questionnaire. So if there's anything else anyone would like me to go over in here, just a bunch of helpful questionnaires. And master subject log. Go back to that. Okay, moving on. Okay, this is also the list of the questionnaires again. So this is a breakdown of what will happen at each visit again, for reference. Those cover sheets are really helpful to make sure that you've done everything and you don't forget anything. It's kind of just like a checklist when you can use it while you're at the visit to keep yourself organized. It helps me. So follow-up visits, of course, are only alcoholic hepatitis patients, and then week 24 heavy drinkers, and they will have these events at their visit. So compensation is something that you will need to discuss with your PI and your site and see what works best for you. We are going to be doing Walmart gift cards. So it's site dependent, so everyone can be different, but we're going to be doing Walmart gift cards, $50 a visit. So of course, heavy drinkers will have 2 visits, so they'll get 100. Healthy controls 1, and then 4 for alcoholic hepatitis. So whatever works best for you is something you need to decide before we can start. Does anyone have any questions on that? Okay. So these are the visit windows. So it's a little bit of leeway because, it's hard to get people to come in exactly. The week 24 visit is a big window, which is very good. So like we talked about, if a subject does not return for their follow-up visit within the visit window, they'll be considered missed. Make sure you fill out the cover sheet, record it into REDCap, and also call the patient using the medical record follow-up form that I showed you. And also remember to make it a protocol deviation and enter that into REDCap. Any questions on that? Okay. Also, loss to follow-up is a little bit different. So if an alcoholic or heavy drinker does not return to their week 24 follow-up visit within the visit window, the coordinator is unable to make contact with the subject. The heavy drinker will be considered lost to follow-up, but the alcoholic hepatitis patient will not. The alcoholic hepatitis patient will still be looked through the medical records until the end of study, unless they withdraw, pass away, or something like that. Does that make sense to everyone? Okay. And early termination, if a subject discontinues participation in the study after enrollment, but before their 24-week follow-up for any reason, procedure will be early termination and should be followed. Complete the end of study form and enter into red cap. So pregnancy reporting, wow, I know nobody is taking drug or anything, but it is important to fill out the pregnancy notification form and let your PI know, and then just follow ward protocol deviation guidelines, and they will be considered off study. There will be two types of protocol deviations. As most of you know, if you've done studies before, we're doing subject, protocol, and study. So when a protocol deviation is identified, such as missing urine, or they decided they didn't want to fill out the questionnaires, please just complete the subject protocol deviation form and enter in a red cap. If a study protocol deviation happens, such as using the wrong consent or something like that, make sure you email or fax the deviation form to IU within 2 business days and see the MOP for additional protocols on that. Does anyone have any questions with that? Okay. So this is just a few helpful tips when filling out the forms that are important when you're getting audited or something like that, that if you make a mistake, 1 line cross through initial and date. I'm sure most of you know that. And then filling out the headers on each page, make sure that all numbers are right justified. And the forms may be used as a source document if the data is entered on the form as the procedure or interview is completed. So that's pretty cool. I remember in our last study we had to fill out 2, so just 1 less paperwork. This is an example of the blood that will be collected at each visit, the number of tubes and everything. The volume of the tubes may change. Amy and UMass and Peter are deciding on the certain kind of tubes, so this is not certain, the milliliters, but this is what IU will be doing for the number of samples. So you'll have to talk with your PI about that. Does anyone have any questions on any of this? Okay. So that is all. Does anyone have any questions or things that they aren't sure about? Did Kayla, Jacob, Janetta, Amy, anything to add?
Nope, I'm good.
Nope, thank you.
Nope, this is Kayla.
Okay.
Nothing on my end. This is Amy. Just want to specify that we're hoping to get the final specimen numbers shortly, so that we'll have more concrete data for that.
Sure. Thank you. So if anyone has any questions and they just don't feel like asking in front of everyone, feel free to email me at any time. I've worked a lot on this protocol, so I know a lot about it. But if that is it, I will let Kayla wrap up.
Thank you so much, Savannah. You did an excellent job. So just to wrap things up, just from what I said before, if there are any changes in the protocol from today till tomorrow, which there may, I will let everyone know so everyone's in the loop. Also, within the next week or two, I will be sending you the clinical trial protocol just for review, but I need all the investigators' approval first. And then, again, just as a reminder, please send me your sub-I's information. And if you haven't filled out the 1572 for the observational trial, I know I have a lot of the clinical trial 1572s, but just the observational trial, that'd be great. And yeah, so thank you so much. Does anyone have any questions or concerns? No? Okay.
This is Jacob. I don't have a question, but I just wanted to remind everybody to create a RedCap account if you can. It really doesn't take long, and they should get back to you within like a couple hours usually. But if you do that, it would greatly help me before our training on Tuesday.
Yes, I forgot to mention that. Yes, the next training Jacob will be presenting. It'll be on RedCap, and it's next Tuesday, January 22nd, from 11 to 12 p.m. Eastern Time.
And this is Peter. To piggyback on that, hello, this is Peter from, I guess, UMass biorepository side of things. The biorepository RedCap and the IU RedCap are two different things. So if you need to be on that other side of things, then you'll need a separate account for that. The IU RedCap will not work for the for the specimen collection system. So you'll need a separate account for that.
Thank you so much, Peter. All right, well, if there are no other comments or questions, I will give you back 13 minutes of your day.
Bye. Thank you.
Thank you.
Thank you.
Have a great weekend.
Thank you. Bye-bye. Bye.